So any questions from the stuff about CF or any other Peds section? Anything at all? Okay. So we'll finish up with some talk of GI disorders in kids. This is a very frequent cause for kids coming into, especially like the Peds ED or urgent care clinics and things like that, just because they have a lot of GI issues that can pop up and be kind of problematic for them. I mentioned probably my cousin knew, and he had his small daughter, and he was like, you know, rushing her to the ER. Like, I think she's going to die. I think she needs surgery. I go, she's constipated, you know. I don't think so. This is the worst stomach pain of her life, and I don't know if she's constipated. Sure enough, an enema later, she felt like, you know, $1 million. So you'll see that, you know, sometimes a Fleet's enema can be the best medicine of all. But anywho, you're going to see that gastroesophageal reflux is going to be a big issue for a lot of these kids, and so it's a very frequent medication that a lot of them end up getting put on. It's important to realize that obviously not meds are going to, you know, meds aren't going to solve all problems, but there's some dietary modifications you can make as well. But you see this especially in premature infants, especially just because of the, you know, not really as mature. They have issues with their lower esophageal sphincter not really being as tightly controlled and regulated, so you end up having a lot of reflux for those kids. So this can lead to a lot of recurrent vomiting, which fortunately my child never suffered, so I'm probably going to get more issues later on down the road, I'm sure. But you end up seeing about, you know, for half of infants in the first 3 months of life have issues, kind of recurrent vomiting. Kind of see how it changes, you know, based on as they get a little bit older. A lot of times this is going to resolve spontaneously, but you may need to treat it kind of in the interim to try to help kind of limit some of the kind of more chronic issues that they may have with that. So we know it's multifactorial. A lot of it could be related back to diet, you know, whether they're being breastfed or whether they're being on formula, you know, just what their anatomy is. A lot of times we have kids coming in to get surgery done just to have, you know, for poor anatomy and things like that, having like Nissens and whatnot to try to help regulate a lot of their reflux. But we'll see that we can't really do a whole lot necessarily to fix that lower esophageal sphincter with medicines necessarily, but we can at least help with the actual reflux, what they are kind of spitting back up, and kind of help to deal with a lot of that. So we'll see a lot of similar meds we saw with GERD for adult patients as well. So if we can help to, you know, increase that pH of the gastric contents and things like that, you don't really see as much kind of chronic kind of esophageal damage being done for these kids. So okay, so for our goals here, we'd like to try to eliminate symptoms if possible. Also, with kids having lots of vomiting, they may not be eating as well, so you may have issues with them like hitting their milestones or dropping down in their percentiles for growth and whatnot. So we like to make sure they can, you know, get enough nutrition. If they have any kind of esophagitis that's developed, we can help to heal that, and then prevent any kind of further complications from developing down the road, and obviously try to have maintenance of that remission and kind of until their vomiting kind of spontaneously resolves. So obviously lifestyle modifications are going to be a big thing here. So dietary modification, we'll talk a little bit about that in a second, but make sure they have, you know, good proper positioning during and after feeding. Obviously hanging them upside down is probably not a good idea, but you know, just kind of common sense things you can make sure that the parents are doing. And then we'll talk about the pharmacologic therapy in depth, and then obviously the anti-reflux surgery as well can be useful here. So one of the things that you can do to kind of help with the reflux for these kids is to help kind of thicken up an infant's formula. To use things like rice cereal to try to help kind of thicken that up, and it makes it a little bit more difficult for it to be, you know, it's not quite as runny, it's more viscous, it's harder for it to necessarily come back up. So that can be useful in some kids. If they have issues of allergies, you can use hypoallergenic formulas. That can be very useful. A lot of times, a lot of these GI issues can be kind of undiagnosed food allergies, so you may need to, you know, to have further workup for that sort of thing, you know, whether it be lactose or different, you know, soy. Sometimes kids will have soy allergies as well. Can be kind of problematic. And then as they get older, you know, especially with children and adolescents, you know, avoid kind of trigger foods. So a lot of, you know, things that they of course want to get a lot of. It's like caffeine and chocolate, but then also spicy foods and whatnot. You know, hopefully kind of keep them from that and kind of help avoid those kind of trigger foods that they know are going to exacerbate those GERD symptoms. We actually tried giving my child rice cereal. We thought it would help her to sleep better throughout the night because it kind of helps stick around for a little bit longer, a little bit harder to digest. It was like giving her methamphetamine. Like, I'd never seen a child so awake in my entire life throughout the entire night. So needless to say, we stopped at the rice cereal. But just be aware that kids can have odd reactions to introducing new foods, especially at nighttime. So anywho, we've covered these meds before, but we'll talk about them again here. Obviously, we can have things that directly try to neutralize the acids in the stomach, so we'll talk about our antacids. We'll also have our mucosal protectants, so I see a lot of kids being put on carafate. I don't really see so much sodium alginate. We'll talk about that as well. And then you have your kind of mainstays for GERD therapy, your H2 blockers and your proton pump inhibitors. And then we'll also talk about some prokinetic agents we'll see being used for these kids as well. So obviously our antacids, they're working to neutralize that gastric acid. So very frequent, we'll see things like calcium carbonate probably being the most common one. Again, it's pretty cheap, easily available. Lots of people have it in their homes. And then sometimes you'll also use things like magnesium aluminum hydroxide as well, or Malox, Mylanta, whatever products you have available there. You don't want to use these necessarily for really long-term use because you can run into some problems with side effects. These are better just kind of as needed kind of therapies. As you might imagine, what are some side effects you can see from like calcium carbonate administration? Constipation, yeah. So you don't want to necessarily stop them up and have issues with that. How about the magnesium aluminum hydroxide? You guys think of any? Well, usually they don't have an issue so big like aluminum buildup like you would see like a chronic kidney patient. You may see some issues like diarrhea or something with this one, but not a ton of problems with the Malox Mylanta. But obviously, these are only going to be good for kind of as needed type symptoms, right? You don't want to necessarily give them all the time. We know that their durations of action are going to be relatively short, especially in comparison to like your H2 blockers and your PPIs and whatnot, right? Also note that there are going to be lots of drug interactions with these because they're going to bind up other medications as well. So keep in mind those drug interactions, make sure to separate them out appropriately if need be. Talked about the sodium alginate or the Gaviscon that kind of helps to form that nice kind of protective barrier around the stomach, kind of help to occasionally help kind of inhibit that regurgitation. But the thing I see more commonly used is probably going to be the carafate or sucralfate. Basically, again, when it kind of interacts with the acids in the stomach, it helps to perform that nice, make that nice barrier there to try to help prevent some of that kind of erosive effects of the stomach acids. Lots of kids get put on carafate, I see, especially on the inpatient side when they might be a little bit more kind of stressed out and a little bit more producing more acids. Usually I see this more as kind of a prophylactic, but it does have to be given several times throughout the day because, again, it's not going to stick around for super long periods of time. I also see this used a lot for kids who, like, especially on chemotherapy for like stomatitis and whatnot. So it's good to kind of help cover some of those kind of ulcers and things like that to help prevent some of the pain associated with that. So I'll see a lot of kids put on carafate for that reason. Okay, so then we have two major prokinetic agents that we're going to be looking at. The main mechanism here is they're going to help to increase that lower esophageal sphincter tone pressure to try to help prevent some of that refluxate from coming back up. And it also helps kind of provide better peristalsis effects. So we see this a lot for kids that have kind of dysmotility of the GI tract. They'll either be put on Metoclopramide or Reglan, and then also Erythromycin are the two big ones you're going to see being used here. Do you guys remember any specific kind of mechanisms of action with metoclopramide and what receptors it interacts with? Yeah, so what does it do with dopamine? Yeah, so it's anti-dopaminergic, right? So it's going to block some of those D2 receptors, and so you worry about things like the E.E.S. You can see with that. So keep the mechanisms in mind. Kids are going to be at risk for a lot of these side effects, just like you would see with the adult patients. Some of them are going to be more prone to certain types of side effects. So you may see things like paradoxical reactions for some of these kids with certain types of medication. But just be aware that they can be at risk for, because the mechanism is going to be the same regardless for those patients, and so you can still see the same problems. But I mentioned metoclopramide being a dopamine receptor antagonist. Again, it's going to help to kind of propulse things through the GI tract a little bit more quickly. So especially if they have any kind of issues of, it looks like they're kind of throwing up and it looks like the food's not really being digested well, they're having issues like that, that can help to kind of move things forward, hopefully have them digest things a little bit better. Notice here that this will be given, along with meal times, typically. Does have to be given, kind of throughout the day several times to make sure you kind of have that continued effect. Again, make sure you're not using higher doses than this because you end up kind of running into issues of having things like the E.E.S, those extrapyramidal symptoms. I don't really, not that I've seen any kids develop tardive dyskinesia secondary to this, but again, you're not using like the big kind of mega doses like we would use for some of those chemotherapy patients, before things like Zofran came out in the market. But could be a potential problem for those kids. And then we mentioned erythromycin. You guys remember that's a macrolide antibiotic. Again, I probably see erythromycin used more frequently as a prokinetic agent than I ever do for actually treating an infection for the most part, right? You may see some erythromycin eye ointment, things like that, but for the most part, you end up seeing a lot of this being used for the prokinetic effects. And mainly what it's doing is interacting with this modal interceptor on the GI tract, and that will help to stimulate peristalsis, kind of move things forward in that regard. Can you guys imagine any kind of problems you might see if you have kind of antibiotics on board chronically? Diarrhea, maybe some malabsorption, like you have some issues if you're kind of disrupting the GI flora, right?
Yeast overgrowth in children?
I don't know that I've seen that personally. I don't know if that's a really big problem with that one. But obviously you run some risk of having what type of infection? Yeah, so you may worry about something like C. diff. So of course, if that develops, and obviously, so they have a really kind of like profuse diarrhea, and you expect a little bit of diarrhea associated with this drug, just due to those modulin effects and also the effects on the GI flora. But if it gets to be really kind of profuse, really watery diarrhea, obviously you'd be thinking something like C. diff, right? So it could be one concern, but it's usually not super common that would occur. Also be aware of the drug interactions that happen here. So if they happen to be on other meds that are metabolized by CYP3A4, they can have those interactions and have increased levels of those drugs being problematic, right? 1A2 also gets affected here as well, so probably less common you see kind of clinical interactions there, but certainly the 3A4 can be problematic. Okay, then you have your H2 blockers. So these are going to be obviously working to block the actions of histamine on those H2 receptors to decrease the actual acid production. So again, durations of action-wise, this one's going to be lasting a lot longer. So again, think about the actual issues with your patient. What the actual pathophysiology is. If it's an issue where they're having kind of peristalsis issues, that's going to lead you to more think a prokinetic agent. If it's really more of an acid overproduction, then you're going to be thinking using an agent like this that actually directly works against the problem that you're experiencing. So we mentioned H2 blockers, lots of them are out there. Which one do I mention to never use? Why is that? Yeah, because it inhibits? CYP. There you go. All right, so we got there eventually. But yeah, CYP3A4 is the big one you want to avoid inhibiting. But again, it's available over the counter, really easy to get hold of, and relatively cheap for the most part. So, for instance, we use a lot of ranitidine over at Nemours. We actually use that as our preferred agent for like IV and PO. But then, of course, you have run into issues like drug shortages. So we actually ran out of the IV form of Zantac. So we had to switch over to using famotidine IV, right? So keep in mind you may need to kind of switch up your therapy based on kind of what's available, what the costs are, and things like that. So kind of be aware of, be able to kind of interchange between any of them, because they all work pretty similarly for the most part. And then your proton pump inhibitors, remember these are working specifically to block that proton pump. So if you were looking at comparisons of efficacy, which one is more potent at decreasing acid production? This versus H2 blockers. Yeah, PPIs are always going to be a little bit more potent, but you're also going to see these typically are going to cost a little bit more. More of them are going to be prescription only, so be aware of that. Certainly, I think H2 blockers are a good place to start for a lot of kids. If they don't respond well to that, then PPIs can be used as well. Obviously, for more severe symptoms, it's okay if you jump straight to a PPI. But what do you kind of worry about kind of chronic, with chronic use of PPIs, what do you worry about with absorption? Yeah, calcium, right? And of course, the kids need lots of calcium because they're developing their bones. So it could be, I don't know that I've actually seen any issues where that is a kind of a noted problem. Like certainly for patients at risk for osteoporosis, that is a concern. But just something to keep in the back of your mind could be a problematic.
Are they all pretty much equally effective as well?
Yeah, I see them being pretty much all equally effective for the most part, yeah. These drugs kind of become problematic, especially if you have kids who have issues with the problem we run into most often with the PPIs is the fact of dosage form, right? So all of these come mostly in capsules, which are filled with these different beads, and the beads are actually meant to the drugs get inactivated in the acidic medium of the stomach, so they're put in these kind of pH protected coatings, so that way when they pass through the stomach and they get down to the small intestine, the higher pH will actually melt off that coating, and then you can absorb the drug. The problem we run into with a lot of these agents for children is that obviously they have problems taking capsules if they're younger, so we have to make up these kind of liquid formulations, and so oftentimes that requires us to kind of like melt off the coating with like mixing it with bicarb and like stirring it for a long period of time, and the stability isn't super good. So dosage forms may be problematic for these kids. They may have to go to a special compounding pharmacy. So usually that's why H2 blockers are the easier thing to go with, because there's readily available liquid formulations that kids can get access to, right? So again, think about dosage forms, think about what is available, what your patients can actually take. Again, you may have older patients who don't tolerate tablets and pills and things like that, so may even need liquid formulations for them as well. Okay, then moving on to constipation. One thing to keep in mind if you're having vomiting with children, especially those that are less than 2, if you think of like normal medications used to treat nausea, vomiting in children, what are some examples? What are some options?
Zofran.
Like Zofran, so that's what type of drug?
What is that?
Just,
It's an anticholinergic.
no. Serotonin, 5-HT3 receptor antagonist, right? Those are great to use for kids. We use them all the time. Again, with kids labeling of medications, they always say don't give it less than what age?
6 usually, like 7.
He's like 6 months, usually age 2, right? So again, when they're doing studies and whatnot, it's hard to do studies on infants and things like that. So a lot of times you'll see that we don't have all the best information as far as actual studies being done in this age group, but we use the meds anyway, right? So just kind of anecdotally, we know these meds work, they're safe, we can go ahead and use them. There are certain ones you don't want to use for nausea, vomiting, especially if they're less than 2. Those are going to be your phenothiazines. So those are going to be things like your promethazines, your Phenergans, right? You don't want to use those because there's actually a black box warning for increased risk of adverse reactions in kids, potentially death. So you don't want to use them in that age group. That does come up somewhat commonly because of the fact that if a kid is not really tolerating oral, and Phenergan comes as a suppository, they'll say, okay, well, I'll just use the suppository. You really shouldn't use it in that young of an age group for kids. But most other meds for nausea, vomiting are going to be okay for the most part. So just be aware of that one kind of interaction you don't want to give for those kids. Okay, so constipation. Again, I mentioned this is going to be a big pain in the butt for a lot of your patients. You're welcome. So anyways, this is going to be usually delays or difficulty in defecation for at least 2 or more weeks. And so you can have a couple of different varieties, especially for kids where they have more of an organic issue due to some kind of underlying disease. So we mentioned with CF, they have kind of a secretory problem, so that can lead to constipation for them. But it could be more functional in a lot of cases to where, they can kind of learn behaviors where, okay, if going to the bathroom is really painful, they may not want to try to go to the bathroom, and that just leads to further constipation. So we know that the continence are really maintained by both voluntary and involuntary muscle contractions, and so they need to be really working in concert to make sure things are moving along appropriately. And the urge to defecate is normally going to occur most often when you have that the stool coming into contact with the mucosa of that lower rectum. So that's where it's important when you see drugs like things like enemas. You're applying a lot of volume to that area, and so that's kind of stimulating a lot of that urge to defecate. So that's why those drugs are so quickly effective. Because they are directly stimulating that urge to go to the bathroom, right? So looking at the normal frequency of bowel movements, you'll see that they will typically kind of get less frequent as they get older. So say something like 4 stools a day in the first week of life, get less and less as they go on. Obviously, you can run into issues where they can go several days without going, and so if they sort of get extra fussy or really not and seem like they're in a lot of pain, could directly be related to that constipation. So again, other things that can lead to kind of painful defecation that may lead to them kind of voluntarily withholding feces would be things like toilet training if they have kind of bad experiences with that, stressful events or other kind of intercurrent illnesses. Lots of different things can lead to them having kind of this kind of psychological issue with going to the bathroom. So just be aware of that. And so you may actually need some psychotherapy to actually kind of help with some of these kids. So not all related just or treated just with medications. But make sure you're checking like medical history. You may find some undiagnosed conditions, and especially with these kind of first presentations of constipation, so maybe some kind of organic issue at play here. But obviously, look for other kind of issues like psychosocial history. Look for other things like infection, things like that. And obviously, the physical exam is going to be useful here. So, like you mentioned, most of the constipation is functional, but other things that could come up, cystic fibrosis, hypothyroidism, neurologic disorders, lots of different things could also be influencing us as well that need to be kind of worked up and ruled out from those standpoints. looking at breastfed infants, things to consider there is you pretty much have bigger variability in their stool frequency, and for the most part, mom may come up and be like, oh, the kid hasn't pooped in a day, like, I'm really worried about them. Usually they just need reassurance, like, hey, every kid's a little bit different, it's going to be fine. But as far as treatment goes, obviously education is going to be a big thing. I think probably a lot of constipation is also related to kind of chronic dehydration for a lot of these kids, where they're not really getting super great nutrition and not getting enough water. So make sure your kids are getting plenty of water. And then we'll look at acute treatment as far as disimpaction goes, and then also maintenance therapy. So obviously our goal is to make sure we're having good, soft stools, once or twice a day. And so that's going to include both, dietary interventions, as I mentioned, like, water intake, behavioral modifications, and then meds. Okay, so we're going to look at kind of both acute treatments for constipation and then more kind of maintenance meds. So if they're having a fecal impaction, you can use kind of a couple different routes, obviously either oral or rectal. The oral is nice because it's not really invasive and gives it a little bit more sense of power to the kid. They kind of think they're doing something to kind of help themselves along. You may see that adherence can be problematic, especially if it's something they're having to take, with some frequency. Rectal, though, is going to be faster and definitely more invasive. So we have one doc who no longer works at Nemours, but for a long time he was the enema king. We needed to buy extra stock whenever he was going to be on shift for in the ED, and so he would give enemas to everyone. So I mean, it's fine if you're dealing with like a 4-year-old, like they're probably not going to be that embarrassed about having to get an enema, but like a 15-year-old female, that gets to be a little bit more touchy. But it's like, nope, enemas for everyone. Get them out of here and get them taken care of. So keep in mind, you may need to look at your age of your patient, kind of what their considerations are when you're deciding kind of what dosage form to go with. So looking for the oral medications, we can use lots of different things. So you can use things like mineral oil, which probably doesn't get used quite as often. You want to be careful with mineral oil if the kid has any issues where they are not able to protect their airway very good. If they have aspiration of that into the airway, that can be very problematic, have a bad pneumonitis associated with that. So especially these kids that may have kind of more more developmental disabilities, things like that, where they're not really able to protect their airway, that can be problematic for them. We mentioned the polyethylene glycol electrolyte solutions. You guys remember any brand names for that? Miralax is going to be the big one. So Miralax is usually going to be more for like kind of daily treatment of that, but then there also is the one we use for like bowel clean outs. Go Lightly, yeah. So Go Lightly is kind of the bigger dosage form of that we'll use a lot for usually preparation for surgery, bowel cleanouts. Like we can use that somewhat frequently. Sometimes we'll have patients who are being followed by GI who end up having very severe constipation. They end up getting admitted to the hospital for some of these cleanouts. So again, it's not one of these things where it can just be kind of a one and done. Sometimes they need a lot more kind of invasive, more kind of intensive kind of care for that. But yeah, so you can use things like those electrolyte solutions. The big thing you want to be careful of when dealing with kids, especially the very young ones, is that you want to not cause electrolyte shifts, right? But we'll talk about one very specific case where you do not want to do that with certain sodium phosphate based enemas and things like that. But the nice thing about Miralax and polyethylene glycol, these electrolyte solutions already contain kind of an isotonic kind of solution. They don't really cause a lot of water to move in or out of the body, and they also keep the electrolytes kind of in order. So that's kind of the benefit here, is you don't see a lot of fluid shifts, you don't see a lot of electrolyte shifts. That's kind of the safety feature kind of built in with that, right? So other things you can use, we mentioned that you can use magnesium and aluminum hydroxide together as kind of an antacid. Notice how both of those kind of cancel each other out, because the magnesium hydroxide causes diarrhea, whereas the aluminum hydroxide causes constipation. So they kind of balance each other out. You can use magnesium hydroxide by itself as kind of an osmotic laxative. Mag citrate can be useful, lactulose, sorbitol, all these different things that are not really getting absorbed super well, but can draw water into the colon to kind of move things along. Okay. Do you guys remember what type of drugs Senna and bisacodyl are? Yeah, those are going to be stimulant laxatives. And so what's kind of the problem with using stimulants frequently? Yeah, not really addicted, so to speak, but they become tolerant to it, right? They become dependent on it. So yeah, so there's a physical dependence on that, right? Because you guys probably just learned that there's a big difference between physical dependence and addiction to substances. But anywho, right, so they become physically dependent on having that exogenous kind of stimulation. So when you take that away, that can actually lead to rebound constipation, right? So these are better for kind of acute use when treating acute constipation. As far as rectal administration goes, probably the most common one that we see being used are going to be these phosphate soda enemas. These are like your fleet enemas that you see being used. Again, black box warnings on this one for use in the very young and the very old. So like anyone less than 2, I probably don't recommend getting a fleet's enema. Anyone usually greater than, if they have renal issues, or, if they're, greater than 70 or 80 years old, I probably would not recommend this either, because there's been a few fatalities associated with causing massive shifts of electrolytes, getting hyperphosphatemic, and leading to some big problems for these patients. So be aware of that. If they're a little bit older, you can definitely get away with using this. It's a very quick and easy way to kind of get the feces moving and get your patient back out into the real world, right? Other things you can use as well that can be problematic for some patients would be things like soap suds enemas, tap water enemas. You don't want to necessarily use these in the very young children, because again, electrolyte shifts, fluid shifts can be very problematic. So just be aware of that. Sometimes you can see mineral oil enemas followed by sodium phosphate enemas. Usually one or the other is going to be fine for getting things moving along. Usually my recommendation for very young children, so like, when my kid ended up getting constipated, we use glycerin suppositories. So it's going to be much better for infants. Usually pretty quick acting for the most part. You're not going to get as kind of a big bang for your buck like you do with the Fleets enemas, but it certainly will work. So just be aware of that. Bisicoidal suppositories can also be used as more of a stimulant. We're kind of working directly there in kind of the lower rectum. So as far as maintenance goes, dietary changes, obviously increased intake of fluids can also be useful, because again, if you have dehydrated stool, it's not really going to want to move anywhere. And then also increase their intake of these both absorbable and non-absorbable carbohydrates. This is where things like prune, pear juice can all be very useful to kind of help stimulate movement of the feces. Again, having non-absorbable sugars in the GI tract can help to draw water in and kind of increase that urge for defecation. And then obviously balancing out their diet with things like whole grains, fruits, and vegetables. Now, one thing I had not considered is that, especially for kids who are breastfed, they typically do not get enough iron in their diet when they're very young. Right? So the mom's not really passing on a lot of iron. So they, when you start solid foods, they're recommending things like meats and turkey and things like that. Things are high in iron. But of course, what does iron do to your bowel habits? Constipation. Yeah, so it's one of those things where it's like, oh, that totally makes sense why a lot of these kids end up being constipated when they first start switching over to solid foods, because they're getting more iron in their diet, right? So all of these things can kind of be playing together, but increasing their fiber intake can all be very useful for kind of helping to regulate that. So other kind of behavioral changes, so regular toilet training, kind of make sure they have kind of unhurried time to use the bathroom, things like that. Obviously keeping diaries can kind of help you kind of pinpoint where the problems might be, and then mental health counselors can be kind of invaluable for some of these more kind of psychosocial kind of issues. But as far as daily treatment goes, I frequently, ever since Miralax had gone over the counter, I see this probably being the most commonly used agent for kind of maintenance therapy for a lot of these kids. So again, you can't really go wrong with the dose, so to speak. Obviously, if you give more polyethylene glycol, obviously you're increasing your risk for diarrhea. Usually, you can kind of say, a gram per kilogram is usually a pretty good dose for kids. So, either usually the dose is like 17 grams or a capful. You can do a half one of those for your smaller kids, but just using something every day like that, which is non-habit forming or non-dependence forming, can be very useful, right? So don't use stimulants all the time. That's really kind of more as needed basis. But something like polyethylene glycol, a little bit every day can kind of keep things pretty regular. Okay. So again, when you're dealing with the infants, I already mentioned things like glycerin suppositories being really invaluable here. Make sure they're getting those, those intake of those non-absorbable sugars. So things like apple, pear, and prune juice can be very useful here. Sometimes things even like corn syrup or barley malt extract. Every grandma's probably going to have her little recommendations as far as what to give kids to deal with constipation, right? They all have their kind of their family secrets for how to deal with that. But again, not recommended using stimulant laxatives. You don't really want to take away their ability to kind of help stimulate their own defecation. Okay, so any questions on any of the ped stuff?
You mentioned with the ICU patients or inpatients, we do GERD prophylaxis. Do we have to prophylax for our NICU and PICU kids?
A lot of them end up getting prophylaxis for GI issues, right? So when I was actually just having this conversation with some pharmacy students, but we're talking about the difference between like adult ICU versus peds ICU and kind of the things you're looking at. So like, if you're looking at like adult ICU patient, like you think about DVT prophylaxis, right? So either putting them on Lovenox or heparin or have the SCDs on. Like for kids, you don't really have to worry about that. They don't really have issues with venous stasis, so you don't have to prophylax them routinely, right? Obviously, they have like major orthopedic surgery, you may need to do something like that. So, but yes, you don't need to necessarily do a lot of, you do typically do GI prophylaxis. So a lot of them get put on prophylactic Zantac or PPIs just for preventing the problem from developing in the first place, right? So they may not necessarily have the issues to begin with, but you can treat that. So a lot, especially the premature NICU kids, when they get transferred in, like the the 28-weekers, 24-weekers, like they usually get put on Zantac most commonly. Yep. I had a good case the other day. Did I mention the magnets case? Okay, so are magnet ingestions bad? I'm asking the question, so it probably means you could. Okay, so right, so you mentioned multiple. Why are multiples bad? Yeah, exactly. So you guys remember the Buckyballs, the little rare earth magnets? They're like, little desk toys. So of course I have like a couple sets at home because when I heard they were taking off the market, I was like, oh, I should have some of these for fun. Now that I have a child, I'm like, I should probably get rid of these. Anywho, we had a 6-year-old, which usually 6-year-olds should know better, right? Usually when we're looking at like intentional versus unintentional ingestions of substances in kids, like usually 6 is kind of that cutoff. So usually if they're 5 or less, usually you can kind of consider it just to be like, well, kids are just being inquisitive and getting into stuff. Usually 6, they should have a little better idea. But anywho, on like a Tuesday night, this kid ends up ingesting a bunch of these magnets. Doesn't tell anyone. Was doing fine for a couple of days, and then finally on Friday, the parents either found out or the kid was complaining of a little bit of GI pain, and so he went ahead and they brought him into an outside ED. They did an X-ray. Sure enough, found a bunch of magnets sitting there in the intestines, and so they transferred him over to us for getting a scope. Right. So GI was consulted at that point. They were took him back to the OR to do an EGD, going with the scope, and unfortunately could not pull it out. So at that point, what do they have to do you think? Gotta open them up, right? So then surgery ends up getting called in. They end up going and unfortunately can't do anything laparoscopically, so it's a little bit more exploratory, so they end up kind of cutting them open. End up finding they did have 2 parts of the intestine that were actually being connected through with the magnets, right? So the big problem with that is what happens when you have those parts sticking together for a while. It's going to cause perforation eventually, right? Because that local pressure is going to cause tissue necrosis, going to open up, and then when you have ischemic bowel, having gut bacteria starting to get out there, it can be very, very bad very, very quickly. So the kid was very lucky; he actually ended up getting taken in, but it could have gone a lot worse had it been had they stayed there for a lot longer. But it's very funny because like the med student who was there went in to go talk to the patient, and he came back and said, "Yeah, the kid's being really quiet. I don't know if it's like he's in a lot of pain." And they're like, "No, he's in trouble. His mom's going to kill him when he gets out of here after they save his life." Yep. So be very careful with magnets if they're multiples, and especially if they're not connected together. So if like 2 of them were stuck together and they were to be ingested, they can pass no problems. When they are separated and they come back together, it can be problematic. Right? How about batteries? Are batteries a problem? Not all batteries are a problem, right? So if it's more of a cylindrical battery, those oftentimes can be passed no problem, right? You still recommend they go in to have a localization X-ray because if they get stuck in the esophagus, you do need to remove that, obviously. But if it's past the pylorus, you can just let it go, right? However, large diameter disc batteries, so like the lithium-based batteries that you see a lot in like remotes and things like that, especially greater than 20 millimeters, those are really problematic because when they get stuck in the esophagus, they end up kind of, the esophagus is normally kind of more of like a flat kind of tube, so it clamps down on it, and having both mucous membranes on either side of that, it starts to conduct electricity, and thus you can end up seeing production of things like sodium hydroxide, and that can actually burn through the tissue. So there's been cases of a kid who ingested a disc battery that was that large, gets stuck in the esophagus, ended up perfing within like 4 hours, and ended up having to, I think he ended up succumbing to that, unfortunately. So be very, very careful with the large diameter disc batteries. Any of them need to have an X-ray anyway, just to make sure that it is going to pass. Otherwise, you have to go in with the scope and pull it out. So be aware of that, but a lot of times, especially in the poison center side, we have to kind of like set the tone for the parents when we say take them into the hospital, right? So it's either like, you need to call 911, have them taken immediately, versus like, okay, well, we'll never get around to it, take them to the hospital, get an X-ray done. But those big diameter disc batteries, that's the ones where we're like, oh no, you need to call 911 and get him checked out immediately, right? How about bullets? Are bullets bad? Yeah, you can actually have lead toxicity from that. So there's been cases where, like a kid with like severe like autism. This is a case report I saw. A kid with severe autism ended up ingesting. Basically, he was eating like pieces of a plastic fork, which the grandparents took him in for that, and they did the X-ray and saw a bunch of like rifle cartridges in his stomach, which had been there for quite a while. The kid had pica, and so they ended up doing lead levels, and that was actually elevated. So the stomach acids can actually start to cause some leaching of that lead. So that can be an issue for some people. Be very careful when you go in to pull them out. Obviously, you don't want any of those to discharge, right? Could be bad. Anything else? Laundry pods can also be really bad as well. You guys remember those? The Tide pods that look like candy. We did have one death that actually occurred. That was a kid who was supposed to get transferred over to Moore's and actually ended up perishing due to that. So especially normally like dish detergents and stuff are irritating, but normally kids get a taste of it, they spit it back out. It's not a big problem. But with those pods, they look like candy. Kid puts them in their mouth, bites down on it. All of a sudden they have a big dose all going down the esophagus and can cause severe irritation and potentially perforation. So that kid ended up actually coding at the outside hospital, and they were not able to resuscitate him. So yeah, beware. Lots of things kids can get into. We're actually going through the childproofing process right now. So it's a lot of fun. You don't realize how dangerous your house is until you have a small child crawling around everywhere. Anywho, okay, so if no other questions, we'll do a review on Thursday, and then we'll have the test on Monday. See you next time.